everyone to our October Community First Choice Council meeting. Happy fall. It's pumpkin month, which is exciting. Alrighty. So our mission at the Department of Healthcare Policy and Financing is improving healthcare equity, access, and outcomes for the people we serve while saving money on healthcare and driving value for Colorado. Okay, and my name is Eileen Saunders, and I am the CFC team manager in the Office of Community Living. Today, we don't have a super long agenda. We'll be going over just some policy changes, a few small policy changes, a few updated FAQs or new FAQs, and then kind of a check-in on this meeting and how things are going. So nothing too crazy today. And then we are recording this meeting, so please refrain from sharing any protected health information. We post the meeting recordings on our website, and in order to do that, we have to make sure there's no PHI or protected health information. If you need any accommodations, such as translation services or closed captioning for these meetings, please don't hesitate to reach out to our HCPF Civil Rights Officer at HCPF504-80A@state.co.us. And we can put that email in the chat. Alrighty, so just a quick update on Community First Choice and the Children with Complex Health Needs waiver enrollment numbers. We have currently just shy of 10,000 CFC members enrolled, which is very exciting. And 240 or so members are CFC only members. So we are on track roughly as far as what we predicted for our enrollment numbers, which is great. And we have about 542 CHCBS members who have transitioned to the new Children with Complex Health Needs waiver at their CSR. And then as a reminder, all children with life-limiting illness waiver members were automatically enrolled or transitioned on first. So the numbers are looking good so far. Okay, and if any of you are new to this meeting, new to Community First Choice, I'll just give a brief overview. So Community First Choice is a state plan optional program that states can choose to implement, and it allows us to move certain waiver services from our waiver programs and into Community First Choice, where it lives on the state plan, and it's accessible to all state plan members regardless of, it's accessible, those services are accessible to all waiver members regardless of the waiver that they're on. So these services that we've moved over as of July 1st are on the left-hand side of the slide. They include homemaker, personal care, health maintenance activities, remote supports, home delivered meals, transition setup, PERS, and medication reminders. And then our 2 participant directed service delivery models in Colorado, in-home support services, and consumer directed attendance support services. So regardless of the waiver program that you're on, members can now access these services or those 2 service delivery models if they're eligible and need those services. So we're expanding access to these services, which is exciting, and making them accessible to members on the state plan as well, if those members meet an institutional level of care and have a need for any of these long-term care services. Okay, so just a brief note on service delivery options. So we have 3 options under Community First Choice that you can choose from for your direct care services, which are homemaker, personal care, and health maintenance activities. So on the left-hand side of this slide, we have a few bullets about agency-based care. Essentially, that's where members can choose an agency to support the provision of those services. And so the agencies provide members with a provider, and members don't have to make any decision-making, or they don't have to provide their own backup caregiver. The agency takes care of all of that, and there's no authorized representative required. I think Erin Thatcher on the PDP team has a really great transportation analogy or a nautical analogy for these that I won't try to replicate, but essentially this is kind of on the far end of the spectrum in terms of kind of participant direction. And then in the middle, we have in-home support services, which is in between agency-based care and CDOS. And that kind of bridges the gap between the two, where CDOS is, you know, kind of complete autonomy over, you know, the decisions that you have for directing your care. So IHSS is kind of a happy medium. It provides support while letting members, you know, manage aspects of their care, such as selecting who provides their care and their attendance schedule. And then CDOS, really, member and their AR have total decision-making authority over hiring their attendant, the pay rates, the schedule, the training, all that. So CDOS is a great option for those who are interested in, you know, total control over their care and who's providing their care. Okay, and then I'm going to move on. If you have any questions about that, we can kind of circle back to those. And we have some members of the PDP team who can provide better detail than I can, but just know that those three options are available to you under Community First Choice, and you don't have to be on a specific waiver anymore to access one of those models. Okay. So a quick note about age-appropriate guidelines. So under CFC, we have expanded homemaker and personal care to children. So children now have access to these services, but we want to, you know, make it really clear that children can access these services, but they must have an assessed need, and age-appropriate guidelines must be followed. So we have norms that are associated with age-appropriate guidelines found on our, in connection with our Children's Direct Care Services Calculator. So case managers, families, as you're going through the service planning process, it's really important to review those norms in the guidelines as they really kind of help dictate what should be authorized for children accessing these services. So if you have any questions about these age-appropriate guidelines, please reach out to us. We're more than happy to help case managers and families navigate those norms as they might be new to some families and to some case managers. But please remember those age-appropriate guidelines must be followed for children. It's very important, and we're happy to answer any questions on those. If you have any specific cases, we can, you know, feel free to email us. Okay. So now we'll get into some policy updates. So first thing we'll review today is an update around our professional and medical information page for CFC only members. So currently, the state, we are not requiring a PMIP for short for CFC only members. It's required for all waiver members. So it is required for CFC and waiver members, but not currently for CFC only members. This decision was made because it's not federally explicitly mandated that we require this form, But CMS, our federal partners, the Centers for Medicare and Medicaid Services, does require that the level of care process be uniform for all of our members. So while the PMIP is not explicitly required federally, it does allow us to obtain some federally mandated information, such as target group information and medical diagnoses, etc. So additionally, this PMIP form language is not in our regulations, but it is in our state plan amendment. So we realized this discrepancy recently, and after discussing internally with our case management team, decided to make a decision long-term to require the PMIP for all CFC members. So CFC only members and CFC members who are also on the waiver. So this will allow for alignment with SPA, but it will also make the entire level of care process more uniform for all members. And in some cases, it will make transition between programs a little bit easier. So if members were on CFC only and they, shortly thereafter decide that they do want a waiver program, let's say in the same year, they can switch to that program without having to get an entirely new PMIP. They'd already have one on file and they'd be good to go. So it's streamlined the process a bit and make things a little bit smoother for members long term. Okay, I'll pause here. I know I've been talking a lot and I see some hands going up. So Amy, go ahead.
I'm sorry, did you say my name, Amy? I missed that.
Yes, yeah, no problem.
Okay.
Go ahead.
I find this a little disturbing, and I'll tell you why. If you are going to do this, I think there needs to be some very clear regulations about who is responsible for getting the PIMP done or the PMIP done and what the timeline is. There's nothing currently in regs. I can show you a lot of appeals that I have filed specifically because people sit in intake for months and because the PMIP is not completed, and it's used as a way to say, well, we can't move you to actual programs or case management, and because we don't have this documentation and you didn't provide it. This is a big problem. One of the advantages of CFC, I understand wanting to have it consistent, but if this isn't thought through, you're creating another barrier to access by putting this back in. So I guess if you're going to mandate this for everyone, we need to find a way to make sure it's very clear who does it and what the timeline is. Because right now there isn't anything in reg, which also means it's very hard to appeal. So clients don't get access to services timely. Thank you.
Thank you, Amy, for that feedback. So we, on our next slide, we do have a few more points about operationalizing this requirement. So we can go through some of those points on the next slide. If we want to, actually, I'll just jump to that now. But Michelle, I think I saw your hand go up.
Yeah, why don't I was just going to speak to that a little bit, but if you want to cover the next slide and get through the information, then I can provide any additional information.
Okay. Great.
And I'll also pop in and take a look at the chats. It looks like we've got some other chats, so I can hopefully cover those.
Okay, thanks, Michelle. Okay, so as far as operationalizing this new requirement, the department is going to work directly with case management agencies on collecting PMIPs for CFC only members who do not currently have PMIPs. And this process will not create any service disruption for members. So please know that we're not intending for any service disruption to happen over this at all. So CMAs, as far as, here on out, please collect PMIPs for all members. So CFC only and CFC plus HCBS members. So a majority of our members are CFC and HCBS combined members. So the process is the same. You're not doing anything new there. You've already been collecting the PMIP, so that's great. It's just now for the CFC only members, you'll have to also collect the PMIP for them. And then for CFC only members who do not currently have a PMIP, we are proposing that PMIPs are collected no later than 90 days prior to the member's next CSR date. And so we want to take your feedback on this proposal and kind of see what you think about that timing. And then ultimately, we would provide all of this guidance in a written format via a policy memo, and then eventually make regulation changes. You know, as Amy, you mentioned, you know, wanting something to be in regulation, we absolutely do too. So we would make those changes when it's appropriate in our rules. Okay, any feedback on this process? Yes, John, go ahead.
Can you hear me okay?
Yes.
So just clarification. So we're processing referrals for people who are CFC only, right? On the premise that they don't need a professional medical information page. And so we're to have to go back and get PMIPs for all of these people. Is that what you're saying?
For anyone who is just on CFC only, correct?
Right, but now we have to go back and figure out which ones we put on and go back and get the PMIP.
So yes, I think that, you know, and Michelle, jump in and correct me if I'm wrong here, but I think that's kind of where the department might be able to kind of help case management agencies, you know, locate some of these members if that proves to be challenging. But Michelle, go ahead.
Yeah, thanks, Eileen, and thanks, Rajan. We do plan on providing lists for the case management agencies. We'll be sending out an email to case management agencies with some information, as well as issuing a superseding memo and additional information about operationalizing it. But yes, we are going to need to get those forms for individuals who originally enrolled for CFC only and they were not collected. And we'll be sending out that information to operationalize that and providing those lists.
Okay, thanks. I just feel like that's just, I mean, I don't, you know, for CFC only, it's a faster process for these people,
Yep.
right? That's how it was designed. But now just as to whoever spoke before's point, it's not going to be that way. So I understand the reasoning. I'm just,
Yeah.
my feedback.
Mhm.
It's just now it's just extra work to go back and figure out who needs a PMIP.
Yep, I completely understand that. It's certainly not the ideal and not what we would have wanted to anticipate. So I completely hear you.
Thanks, Michelle. Megan, go ahead.
Yeah, I mean, we've spent the last year talking about change fatigue, right?
Mhm.
And how everybody's just struggling to keep up. And so, like, I get it. This makes sense. It makes sense that it would be there, but you didn't start that way. And changing things again in a system where people can't keep up with all the change, that is what's frustrating. Like,
Yeah.
couldn't you just let the dust settle for a second before changing something else? Like, it's not that the form's that cumbersome, it's just the change piece that has me frustrated.
Absolutely, Megan. We hear you, and I totally get it. This is, you know, definitely not ideal. So, you know, we apologize for having to make this change, but I'm hoping that, or we're hoping that the sooner we can make it, the less work it would be to go back and collect PMIPs for, let's say an even greater number of CFC only members. So right now, I think we're under 300 CFC only members total. So hopefully, we can get all these members PMIPs and kind of move forward from there. But I hear you. It's not ideal just so soon after we implemented. So yeah, we apologize for having to make this pivot.
Could I just add, Eileen? I just want to make sure it's certainly something that we took under consideration in deliberating and making the decision, as well as moving forward how we are going to operationalize that with your partner, the case management agencies and members partnership, and trying to obtain those documents. I'll say too, I saw some of the chats. We do have the proposal of the 90 days prior to the next CSR. You'll see that we are looking for some feedback about that. And we'll be kind of seeking that from our case management partners as well. So that is not something that is a done deal. We want to have some engagement and dialogue about what makes sense for that. So I just wanted to point that out. And then I know at least Amy, you were on the call when we spoke to the ASP stakeholder group and let you all know that we were starting to kick off the process of looking at the PMIP form and other kind of intake documents, those kind of more clinical or medical documents required for enrollment across the programs. And we've shared that information with our case management agencies that that's something that we are looking to do. I don't know how familiar folks on this call are with the temporary requirements around the PMIP that we put into place April of this year with regards to getting the PMIP before doing the assessment. That is currently in place, like I said, since April, and we do plan on putting out a superseding memo to continue that practice, because that is part of what we're looking at as far as our medical documentation, the timing of when it should be collected, in order to see if there can't be some resolution around, Amy, kind of what you were speaking to about the fact that sometimes if that's not received and they've had the assessment, then it proceeds with a appeal process, etc. So that is temporarily in place now, where case management agencies are required to get the PMIP before proceeding with the level of care assessment, so that months don't go by only to be then terminated after the assessment's done. So I just kind of wanted to let everybody know that, one, we did thoughtfully consider what our options were and the impacts that it would have, and the impact of having to go back and get some of these forms. Thankfully, at this point, as Eileen was saying, trying to do it now will minimize the number of members that we have to go back and get those forms for. They're pretty low right now. We'll be providing some more information to case management agencies moving forward, but we'll also be continuing to work on this in our overall project, looking at those that medical documentation that's required for enrollment.
Thank you so much, Michelle. Okay, I see Amy, you have your hand up.
Yeah, I guess I have a couple of questions then. First, it would be really helpful to understand what the stakeholder engagement is going to be around this. You say you're going to talk to some members and CMAs, but how is that going to happen? Is it just going to be we have to send comments in? Are you going to have a dedicated meeting about it? How is that going to happen? Because this is I know it's only 300 people, but you're making this change and it's not coming with regulations that make it clear who's responsible for the PMIP to start out with. Because I know you're saying that in April, there were past, temporary regs. It says that this stuff cannot happen until the person has the PMIP, but it's still not clear who's required to get that or that doctors have to give it back. And on the ground, it's just not happening. So that's question one. Question two, this trend of just putting stuff in memos and then not putting things in regulations for months and months and months, this disempowers people to appeal when there are problems. So I'm wondering if we can also get a timeline of when regulations, maybe even emergency regulations, are going to be proposed so that members have something to stand on and look at, because administrative law judges don't always look at policy memos. Thank you.
Thank you, Amy. Those are good questions and statements. So one, what is the stakeholder engagement process going to look like? We're still looking at how we're going to do that. We're trying to consider the fact that a lot of our stakeholders get engaged on lots of different things, and it's a very busy time right now. So we are working, we actually have, in my section, we're working with a contractor to help make some recommendations around that. And so more information is coming, but we do anticipate that it's going to be more than just submitting comments, and definitely more than what the notice requirements are around like rule promulgation. Like we intend it to be robust engagement with both our case management agency stakeholders and our membership stakeholders. That's why we took that information to you all at that smaller group that we have been working with for a really long time, right? So don't have the details yet for you, Amy and everyone, but we do plan on robust stakeholder engagement around all of those medical documents and that process for intake across all of our programs. The second one, you are not speaking on deaf ears. I feel really strongly, Amy, too, about the fact that we have leaned on utilizing our policy operational memo process while we've been trying to implement all of this change and not able to like promulgate rules in a timely manner. So that is definitely something that I acknowledge and we are working really hard to do. I know for this situation, Eileen and that team will be working on promulgating rules, and we will be working on promulgating rules for our conversation about the PMIPs. And we have, where we're at right now, Amy, is we had a lot of policy for case management redesign that we had to get in writing. So we did utilize the memo process for that. Because it is a long process to do the rules, we have issued all of the memos that catch up with the policy from case management redesign. And so we're actually moving into that next phase to transition all of that information that was put into policy memos or operational memos and getting them promulgated into rules. So that's actually a part of that contract that we have that we're working on, not just with stakeholder engagement, but also what our schedule will be to get those rule promulgations completed to catch up with what's in policy memos. Would you like more detail?
Michelle, thank you. And I know it's not just you. I appreciate the clarity around this that you're sharing. I guess my concern is that HCPF with Nurse Assessor and other things recently has been doing programs. They don't work, then they change what happens. And then, as Megan said, people try to catch up. If there's any way to get the regs in place first, If there's any way to slow down the train, we still don't have nurse assessor working, and this is going to be going to a lot of the same clients. So
Yeah.
I'm not saying anything that you haven't heard before.
Mhm.
So I appreciate your commitment. I and CCDC are very interested, along with people here, in making this work. And I'm also worried about our case management. I'm wondering, are they going to get paid any extra? Are they getting any extra time? Because they have so much on their plates right now. And this just seems like the extra straw. So I don't know. If you have more you can share later, that would be great. I'm very concerned about what every one of these little changes is going to do to our CMAs as well.
Yeah,
But-
I appreciate that. I appreciate your partnership and your advocating for case management agencies as well. Obviously, that's kind of the umbrella that I'm in, and that's what I'm speaking to as far as trying to get that policy into the rules for their sake as well as the members' sake, to the points that you mentioned, Amy.
Thanks, Amy, and thanks, Michelle, for that dialogue. Okay, I see, I'll go to Tara. You are next.
Hello. I just kind of wanted to give you guys a different perspective, kind of coming maybe from like the home health side and kind of speaking to a little bit of what Amy has said. I mean, we are seeing a lot of families that we are referring into the case management agencies to start waiver processes, mainly because if they go into CFC, we want them to get that difficulty of care, covered so their income doesn't go against their benefits, right? And this is something that I am seeing where things are sitting in intake because the PMIPs are not, they're not being received on the case management end, but then I'm calling physicians and I'm getting it that same day. So I don't understand, and this is across a couple different CMAs that, I don't understand where the lack of follow-up is. I know that they've got a lot on their caseloads. I know a lot of people are going through the program and changes to their current benefits, but I think that because there's that lack of regulation on a time frame in which these need to be followed up on, either being put into the system for follow-up notes or just communicating back with families. I had a family sitting just without any communication since February. And because she didn't understand the process or the resources, she just sat and waited. So I don't mind on my end, helping these families. It's what I do. And I previously worked for a case management agency. So thankfully I understand a little bit of what happens, but we're seeing a lot of families sit, and I don't mind, like I said, I don't mind doing it, but when I'm adding that task to my, to my already ongoing never ending task list of having to follow up on these documents for the case management agencies and still getting them, same day, maybe even within a few days, it's making me kind of question where their, I don't want to say competency, that's poor choice of words, but it's kind of making me wonder where the follow-up is for these families, because if they don't understand the process or their resources, they don't have anybody else advocating for them to get the ball moving.
Thank you, Tara, for that feedback. Yeah, that's definitely concerning for us to hear. And Michelle, I'll let you weigh in a bit here. Is this, Tara, I think you're kind of speaking more to the problems of PMIP and case management backlog at large. So.
And that seems to be the biggest one, right? Like, I understand that, I've got families that are waiting at the county level for things to get approved, right? So, but when we're looking for that initial process for things to actually get pushed through, I think the biggest one that we're seeing is, the physician attestations and the PMIPs.
Yeah, and it sounds like we need to, and to Amy's point, maybe articulate better in rule, but in other ways as well, the responsibility of case managers to proactively follow up on those kinds of things. That's what I'm hearing you say, is that you're identifying, and particularly maybe some specific CMAs that need to have that reiterated and some additional oversight being provided. Is that what I'm
Yeah, and I'm assuming, I mean, if I'm dealing with it from,
Yeah.
2 to 3 different case management agencies, I'm assuming it's probably across the board, right?
Yeah.
I know from previously working, I used to work at RMHS. So, previously working, I know that HCBUC has timelines for everything, right? So, and if it's not within that time frame that things can be completed, everything's being documented into the bus. So I understand. And it's been a few years since I've been in the game as far as case management goes, but I know, and I've got a very well working understanding of, how things process, pretty regulatory with you guys, and I attend all these meetings. So I just think that having those regulations in place of, hey, we need these, I think people need numbers, right? They need a specific time frame in which they can complete things and feel like they're being successful. And if they don't have that, then that's, I think, when some of these situations like the PMIP or the physician attestations are being pushed to the backside because other things that have timelines and deadlines are being prioritized.
Yeah, I don't disagree with anything that you said.
And unfortunately, that's just the hard part, because without the PMIP, especially if they're going for waiver services, they're not moving anywhere in intake. And so they're just sitting there. But then the other secondary piece of that is lack of communication with the families. Because I know families that are willing to call the physician and be like, I need this, right? Like, I need you to send this now. I've had people say, well, we've already faxed this. We faxed it 2 and 3 times. They haven't received it. Cool. Can you fax it to me? I will get it to them.
Yeah.
So I know that there's families that are willing to also do the same outside of myself, but I'm really concerned if you're adding additional weight to having everyone being required to have this, we're going to see even more delays in people getting pushed through for services.
Yeah. And Tara, I think that we have to move forward with the change. That's where we're at right now. I think what we want to be able to do is work with you all, work with case management agencies to identify how we can remove some of those barriers, right? Part of that is the goal is to identify the least amount of information that we need to get from an outside source, that being like the physician's, doctor's office, whatever, and identify what the best process would be. And so that's where we're hoping to partner with you all moving forward to see how we can address those issues. And to Amy's point, get it into rule.
Perfect. Thank you. I appreciate it, guys.
Thank you.
Thank you. All right, I see Ellen, got your hand up.
Good morning. Can you hear me okay?
Yes.
Great. So Ellen Jonesby with Alliance. I just want to echo, the concerns that others have about the additional burden this is going to place on families as well as case management agencies. And I guess I just want to dig a little bit deeper. So it sounds to me like what you're saying is that for CFC only members who have not yet enrolled into CFC, your proposal is to get the PMIP collected no later than 90 days prior to their next CSR date. But you're also simultaneously saying that for people who have already enrolled, you're going to direct CMAs to go back and collect the PMIP for those members. Is that correct, first of all?
So I'll clarify, for CFC only members who currently don't have a PMIP, we're proposing that the PMIPs are collected no later than 90 days prior to their next CSR. So let's say a CFC member, CFC only member enrolled September 1st last month, and they don't have a PMIP. So 90 days prior to next September of 2026, that would be when we'd want that would be when we'd want their PMIP collected.
Okay.
Does that make sense? And then
Yes.
for any member who, from here on out, any member who's newly enrolling to CFC only, we're just asking that case managers collect that PMIP right out of the gate, just as they would for a waiver member.
I see. Okay. I appreciate that. Just, I understand HCPUS's desire to want this to be consistent across programs. I guess, is there anxiety on your part about like federal reimbursement for these services or anything, or is this just sort of an attempt to clean up? Like, I guess, what are the potential ramifications if you were to hold this off for a year?
That's a great question. This, as we stated before, this change really accomplishes multiple goals for us long term. We're not concerned about reimbursement, but we do want to make sure that we have alignment across our programs with the level of care process in its entirety, and to make things easier for members holistically long term. So that's also a big part of this change. And again, Michelle, let me know if there's anything else you want to hit there. But I think we deliberated, as Michelle said, internally, and this solution is what we think long term is best for everyone.
Okay, my last follow-up, unless Michelle wants to chime in, is just that with respect to the stakeholder engagement that you plan to do you plan to hold off on directing CMAs to begin doing this until the completion of that stakeholder engagement or not?
So the stakeholder engagement that I was speaking to is with regards to the larger project of kind of reimagining the PMIP and other medical documentation needed for the intake process for programs. With regards to what is up for proposal right now with CFC and the PMIP being required for CFC only, that is only like subject to getting those PMIPs for those that are already enrolled and did not have one collected. So that's the proposal at hand right now with regards to that. Is what do you think about the proposal about just getting those kind of backdated version? Backdated's not a great word, but getting those PMIPs for those folks just 90 days prior to the CSR. Does that help answer your question?
Okay, that's helpful. Yes, maybe I was conflating a couple of different things we were talking about. Okay, well, we're anxious to hear from our CMAs, and I am curious if there's any other formal communication to CMAs planned outside of this meeting, understanding that many of them may not be in attendance today. At Alliance, we represent many of, but not all of those CMAs, so we're anxious to hear from them, their reaction to the proposal in order to provide you with that feedback.
So what I can say, and Eileen, you can speak to, I guess, the subsequent memos, et cetera, but we will be sending out an email to our case management agencies today, reiterating the information we're sharing with you, giving them just some additional details as far as numbers, and then the subsequent lists for the individuals that we would be having them collect those PMIPs for those who have already enrolled. So that information is forthcoming within this week for them. And then Eileen, you can speak to memos, et cetera.
Yeah, I think that, we're underway with our policy memo process for this issue. And so we'll, get that out as soon as possible, and get that out through all of the channels, and, you have any questions ahead of time, ahead of that, Ellen, like, please feel free to reach out.
Okay, thank you. You know, I'm not as in the weeds on the actual processes as many people on these calls are. But, you know, I do have concern that it sort of sounds like, you know, this is moving forward regardless, especially with all the concerns that have been voiced on this call about delays and workload and all of the things. So we certainly will reach out as we gather feedback. Thank you.
Thanks, Ellen. Okay, Megan?
Yeah, kind of tagging on to the end of what Ellen was saying about the stakeholder engagement process. I just wanted to take a second and give feedback on that as a whole within the department, because what I'm seeing more and more, feeling more and more is it's kind of like, did anybody ever do the like love and logic with your toddlers, where it's like you give them two choices and then they feel super empowered because they've had to choose between the brown shirt and the blue shirt. So now they feel really part of this process when the parent has really made the decisions already. That's what this feels like. It's like the stakeholdering version of, do you want the blue shirt or the brown shirt? This big decision has already been made. And so like, we're not toddlers. And so like, if you, I don't know, some of the other committees, like some of the PACs and some of those, when they bring items to stakeholders or to the committees, they bring them with this sort of ranking of what is the purpose of this conversation. Is it to inform? Is it to collaborate? Is it to co-create? Like, what's the purpose? Why are you bringing this to us? And I think that would be really helpful in some of these conversations, because I think we came into this thinking you were asking like, we want to do this form. What are your thoughts? Should we do it or not? And then the more we talk, it's like, oh, no, you're informing us. That decision has already been made. We can give you feedback, but you've already made the decision. And so like, let's go into it that way rather than us feeling like you asked us questions, we gave you feedback, and then you're ignoring it.
Absolutely, Megan. Thank you for that. And we can definitely do a better job of making that more clear, making it clear on what exactly we're looking for feedback on. So, yeah, thank you for that. Totally understand and hear that. And we'll do a better job of that ongoing. Irina, go ahead.
My question is not about the PMIP. I did put in the chat and somebody responded, Rachel responded. I'm still concerned about people over 65. So Medicaid eligibility is to for people birth to 65, and they switch to Medicare. So previously, the only workaround was to have them apply for the waiver so they can receive long-term services. With CFC, a waiver program is not required, but it seems like for these folks over 65, it still has to be done that way for them to either remain on the waiver or to get them on the waiver in order to have Medicaid and access CFC services. Has the department brought this issue up, and is it being worked on to have it done a different way without the waiver, which, as we know, takes a long time to apply for, qualify for, financial eligibility, all that? Is this something that can be done differently for older folks?
Thank you, Irina. I'm not quite sure I'm following your question or concern. What I think I'm hearing is I guess I should say, first up, is your question in regards to the PMIP topic that we're on at all? And as far as the population you're referring to?
No.
With this change, okay. So for members who are on CFC without the waiver program, there's no age requirement. So there's no age limit. If that's helpful, I may need you to restate your question again, because I'm not sure I'm following.
So if you Google or go to Department or Health First Choice Colorado and Google a simple who qualifies for Medicaid, the answer is anybody up to 65 years old. So age limit is a factor because then they go on Medicare, and Medicare is the insurance of choice. To get back to Medicaid, they have to have a waiver.
So for long-term care specifically, there is no age requirement. There's no 65 age limit. So for
Right,
CFC
but long-term-
specifically, the enrollment process does not change regardless of age.
But long-term, that means the waiver, right?
Waiver programs and CFC and our other long-term
Which is
care.
not a waiver per se. The
Correct.
CFC is a
CFC is
Medicare.
not a waiver. But it's a state plan program, but members can be on CFC on Medicaid over the age of 65. They're not going to be pushed off the program when they hit 65.
Maybe I'm not expressing my thoughts. I don't know if Amy, she raised the hand, if she has something to add, maybe.
Yeah, Arena, are you talking about the disability determination? Because when you move after 65, you're on Social Security retirement, that may be 65 to 67. All of a sudden, your Social Security disability assessment no longer counts. At least for Medicaid buy-in, these people, in order to stay active, have to go through ARG eligibility. Is that what you're speaking of, or am I completely missing it, Arena? Because that is an important paperwork thing that sometimes gets lost.
Maybe that's what it is.
Okay. Well, I don't know that we have the right eligibility folks on the call to help tease through this, Arena. So maybe we can connect outside of this meeting if you want to send us an email and we can try to answer your question and bring in the right folks.
Sounds good. Thank you.
Okay, thank you. Alrighty, I see Megan.
Hi, I just wanted to add some feedback in regards to what Megan Bowser and Ellen had stated. I'm from a CMA, and kind of what they were saying, when these decisions are made and it's not for feedback, it's kind of like, this is how we're moving forward. I think it's hard for CMAs to find out the information like this because now all of our advocates and providers and families know about this change, but we might not. So maybe like in the future, if you have a decision made, if you could tell the CMAs so we're prepared for the calls and the emails and the things we're going to get, because only part of us are on this call and maybe by chance. So I think that makes it really difficult for us to be well informed. So maybe when a decision's made, if we could know before everyone else knows, it would be really helpful for us to make sure we're doing our jobs correctly. So just some feedback.
Absolutely. Thanks, Megan. And I do know an email either went out or is going to go out to CMA's directors. So, but yes, in general, absolutely. And thank you for that feedback. Okay. Anything else on the PMIP before we move on? Okay, with that, I will move us to our next policy update. Okay, so we have currently our legally responsible person definition does not include common law marriage for adult members. So we would like to propose including that into our definition. And we have that redlined here on the slide. And then this change would be outlined again in a policy memo until our regulation is updated. You know, again, we hear you in terms of wanting the regulation updated when these changes take effect. So we're working on that, but you know, in the meantime, we want to make sure that this is, you know, out there in a policy memo so that we can get clarity out there to all of our members and our CMAs while regulation is being updated. So we propose that the definition read as follows. Legally responsible person means any person who has legal responsibility to care for another person, which includes the parent or guardian of a minor child or an adult member's spouse, in parentheses by marriage or common law marriage as defined at 8.100 in our rules. So I think, oh, Danny, go ahead.
Yeah, I just wanted to jump in and add to this too. We're not necessarily like changing the parameters of legally responsible person. This is guidance that we've been providing since legally responsible person became a definition back in July. We just get a lot of questions about if common law marriage is included in that, which it is. And we've gotten questions about what all is included. So we really wanted to update the language just to make it clearer for individuals, but we're not necessarily changing the parameters of the definition itself, just adding that clarifying language.
Yes, thank you so much, Danny. Yeah. So, you know, I guess to be clear about the feedback that we're looking for here, as far as there's no actual policy change happening, as Danny stated. We just want to make sure that our language in our definition covers the intent, like the entire scope of legally responsible person. So I think the feedback we're looking for is this clear in definition? And does this make sense if we have it written this way? So Megan, I see your hand. Go ahead.
Yeah, I think Angela has a good comment in the chat. My piece was, while you're in here clarifying with a memo, it would be super helpful to have it explicitly stated that even if somebody has legal guardianship of an adult, they are not considered a legally responsible person, because this gets confused all the time that guardians of adults are not included.
Thanks. That's good feedback, and we'll take that piece back. It's a good reminder.
Yes, yeah, that's true. We get asked that a lot too. So that would be good to incorporate. Okay, any other thoughts? Chris, go ahead.
I'm just wanting to clarify that this is the common law marriage piece is only pertaining to adults, and that a common law partner would not necessarily have legal responsibility for the other partner's children. So this is really about adult care and legally responsible people for an adult, correct?
I believe so. Danny, correct me if I'm wrong. So
I think I just want to clarify the ask. So Chris, are you asking like if the parents are common law marriage, does that impact like if they're a legally responsible person to a child?
Yes, I would not think that a common law spouse is necessarily a guardian to that person's partner's children.
Thank you. Yeah, I will need to, so I'll just read what the regulation states for common law marriage. And I think that that can kind of help clarify some of the questions that are coming in. So the common law marriage is legally recognized as marriage in the state of Colorado under certain circumstances, even though no legally recognized marriage ceremony is performed or a civil marriage contract is executed. But individuals who declare or publicly hold themselves out as a married couple through verbal or written methods may be recognized as legally married under state law. So that's the definition for common law marriage. So I think that might answer some of the questions that are in the chat. And then Chris, specifically to your question, I don't believe that like a step parent is considered a legally responsible person for a child. And so the common law marriage definition is really going to be specific to adults with their spouse.
Thank you, Danny. That's what I thought was probably the case. It just wasn't, I don't think, clear in that regulation.
Totally fair. And I'll just clarify too, this is a generalization. I'll say if there's an instance where a common law spouse has guardianship over an individual, over a child, or has legally adopted that child, then they are also a legally responsible person. But it's going to be tied specifically to the guardianship of that child.
Thank you. Thank you. Thank you.
Right. So Danny, like the intricacies of a partnership, common law or not, what it boils down to for child is having that guardianship. So not to get caught up in the legality of a partnership. Kevin, go ahead.
Hi, so sorry. I just want to make sure I'm clear. So a step parent would not be limited to the 10 hours of homemaking?
Oh, sorry, Danny, I saw you come off mute. But
I was just going to say, the legally responsible person still is limited to 10 hours a week of homemaker care. So if an individual meets this definition of a legally responsible person, they're not permitted to provide more than 10 hours a week of homemaker.
Absolutely. And a step parent would, as we're talking about, unless they have adoption or guardianship, they would not meet that definition of LRP?
Correct.
Okay, thank you so much.
okay, any other questions?
Hi, I have a question. My name is Mariah, and I'm late on the call, unfortunately, so I missed pretty much everything. But I was wondering if, like, I have a disability, and then I have 3 kids that have a disability, and then I have a daughter that's over 18, and she wanted to be a caregiver, but I have a caregiver. Like, how does that work to where, like, you stay in compliance, but everybody gets the care that they need?
Thanks, Mariah. I think for the specifics of your case, if we want to dive into that, I think it's probably more appropriate that happens offline.
Oh, okay.
So if you want to go ahead and send us an email, we're happy to connect with you and we can spend more time making sure we get into things, if that works.
Yeah, thank you.
You bet. Okay, Allie?
Thank you, Eileen. Can you hear me?
Yes.
Going back to the guardianship adoption paperwork for step parents and caregivers, do we need to provide a specific state Colorado documentation or certification for legal guardianship other than just the forms that we as a household accept it? In a specific case, adoption paperwork might be in the works, but for the last 8 years may only have just a signed paper stating from biological father, since biological mother is no longer in the picture, that is a guardian. Are you guys requiring any other specific documentation that states the legal guardianship? Are you requiring that?
I think that question is gonna expand outside of just like the benefit subset, which is what we're able to speak to today.
Sure.
So I think we're gonna need to take that back just
No
to
problem.
some of our other teams, because I'm not entirely positive what is required as far as documentation goes.
Okay. Okay, perfect. Thank you.
Alrighty. Anything else? Any other questions on legally responsible person definition? Okay, with that, I will move us to our next, and I believe our final policy update. Or maybe second to last. I think there's one more after this. I apologize. Okay, so we are proposing removing the physician attestation form for in-home support services. So currently, in-home support services rule requires a physician attestation form for all participants. The purpose of this form is for the physician to attest to the member's capacity to self-direct services. So the goal with removing this form would be to align language with CDOS and not require it for children, because individuals under the age of 18 are required to have an authorized representative. Again, this change would be outlined in a policy memo until our regulations are updated. So again, we'd be removing it just for the children's population to align with CDOS. CDOS also does not require it for children. And we would update this in regulation when we run these rules. So any questions about removing this form for children for in-home support services? Irina, go ahead.
Yes, that would be a good change, but also since physician attestation only requires the physician to attest whether they need an authorized representative or not, can that language be a part of PMIP since it's already being sent to the doctor? Can it be just one document that combines these two?
I can take that question. Good question, Irina. That's definitely something that we have put some thought into and we're interested in exploring more. At this point, the IHSS physician attestation of consumer capacity has some more specific language about the IHSS benefits specifically, such as what additional supports may be required. And then it's speaking directly about the IHSS program, and if that individual has like the mental capacity to self-direct their care. I think we are interested in exploring if it could be consolidated, so that we don't have multiple forms. But I think at this point, it's not something that we're able to do immediately, and that would be a long-term project that we need to look into more.
Thanks, Danny. Okay, any other questions or comments about removing this form for children? Okay, well, I saw a lot of thumbs up emojis, so I'm hoping this is a positive change. But again, reach out if you have any questions after this meeting, if there's anything else you think of. Okay, and then the last change we have today is around extraordinary cleaning. So currently the provider agency requirements section for extraordinary cleaning does not include language on organized healthcare delivery system, or OHCDS for short. This does not align with other benefits that use OHCDS. So we are proposing just adding the following line, that extraordinary cleaning is authorized for organized healthcare delivery system. So again, this is not like a policy change, but more clarification that makes things more unified and clear in our rules. But it doesn't change anything about extraordinary cleaning. We're just making it clear that it can be authorized for organized healthcare delivery system. Any questions about this? Molly, go ahead.
Thanks, Eileen. Can you just do a little brief definition of what OHCDS is?
That is a great question. I am going to have to tag in one of my colleagues because I don't think I have the best understanding of it myself. So Danny or Amanda, would you be able to help me out?
The official definition and share it here just in a minute. Just at a high level, the OHCDS is really it's the opportunity essentially for the case management agency to kind of act as that middle person between the provider and the member. So this mechanism is used a lot in instances where there aren't a lot of available Medicaid providers. It's not permitted for most of our services, but there are a few where it is allowed. And I can get the official definition for some additional clarity and share that with y'all here in just a minute.
Thanks, Danny.
Yes, thank you, Danny. Okay, any other questions? Daniel, go ahead.
I have one that's not related to this. Was there going to be like an open forum after this, or?
There is, yes.
Okay, then I'll hold off.
Okay, thanks, Daniel. Alrighty, with that, I will move us along. So just to wrap up that last section, again, these changes will be reflected in policy memos. So look for those. And we will, of course, bring you our red line rule updates when the time comes to incorporate these into our draft rules. So I want to just go over a few new frequently asked questions that we've received over the last month about CFC, and just to share them with you all today. They are also posted on our FAQ on our CFC webpage. That FAQ is updated every week or two, depending on how many questions we get, but it is a living document. So please continue to reference that, as it has grown quite a bit and has a lot of good information on there. So you can find these questions on our FAQ as well. So we've been getting questions about, if a member had a 7/1 start date or later. So, let's say they had a CSR this past summer, and they chose, they did not choose to enroll in both CFC and HCBS, but now they want to choose CFC and HCBS after that CSR process has concluded. Do case managers and members have to have a change in condition submitted for these cases? And the short answer is no. This is not a situation where a change in condition requirement needs to be met. That requirement was only for early enrollments into CFC before the members scheduled CSR this year. So, if the members already had their CSR, but they want to switch programs, they can do that with their case manager at any time that's convenient. They will have to go back through the 100.2 and make their new selections and close out their current program, which is, I know, burdensome for case managers and families. But at this time, that is what they have to do. So, yeah, Cheryl, go ahead.
Hi, yeah, just a quick question. If they decide to do that, does a new PMIP required to do that? Or because we're changing to a new program, like a waiver change?
I don't believe so. But if they were on CFC only and they didn't have a PMIP and
Sure.
now they want a waiver program, then yes, they're going to need one. But Michelle, I don't know if you're still on. I think it might depend too on the case, but I
mean, I would think if they were honest, they were just getting their CSR and we added CFC because that's where their services were at. I would think we wouldn't have to. But just curious.
I agree. I don't think you would need to get a new one. But you know, if anyone from case management is on, please correct me if I'm wrong, but they may have left. So I can take that back and clarify for you, Cheryl. Oh, Lana, go ahead.
Hi, Eileen. Sorry, jump in here. Not on the case management team, but have been working closely with Michelle on this pivot and that requirement for the PMIP. Our intention is to have the PMIP required for initial enrollment only, so that kind of transcending into these kind of back and forth of programs. So our hope is that we will just have the one PMIP for initial, and then if a member moved, you know, from a waiver to CFC or from CFC to a waiver, that PMIP will stand. And we will make sure that that is clear in the policy guidance that we issue.
Great. And then we'll move on to the next FAQ. So under CFC homemaker and personal care, we've been asked if the person receiving services has to be present for the provider or staff to deliver the service and bill. So for homemaker, the answer is no. A member does not necessarily have to be present in order for that service to be completed. However, for personal care, the answer is yes, as personal care is a one-on-one service with the member and they need to be present. Any questions about this one? Oh, sorry, Megan, go ahead.
Sorry. I would recommend just adding to this clarification around if the homemaker is AME homemaker, then the member would have to be there. So that clarification might be helpful within this. I think this also lends to the question or the thing we run into a lot, that a member could theoretically qualify for more than 24 hours a day of services under CFC if some of those were homemaker, which would be provided indirectly. So they could be getting personal care by one provider while a separate provider is doing homemaker simultaneously. And we get that question a lot.
Thanks, Megan. Yeah, that's a helpful feedback around AIM, and we can certainly edit this response to include that clarification. As far as the second part of your note, I'm not sure, or of your feedback, I'm not sure I'm following, but Danny or Amanda, jump in if you are and don't need Megan to repeat that last part.
My apologies. I was responding to questions in the chat and I missed what Megan said. So I'm so sorry, Megan. Do you mind asking again?
Yeah, so I think we run into this, like, when can two providers bill Medicaid simultaneously? And a lot of agencies will say never, never, ever. And we're like, no, it's just if it's duplicative. And so I think this homemaker piece plays into that as well, that a member could be receiving personal care or HMA or some other Medicaid service that is that direct one-on-one, and simultaneously be getting homemaker services happening during those same hours of the day because that homemaker is not being provided one-on-one and directly. And so I think some clarification from the department about that would be super helpful, because in theory, a member could qualify for 25 hours a day of care, 24 being direct and 1 being this indirect homemaker that could happen simultaneously. And so that gets confused a lot and errs on the side of people getting fewer services than are actually needed.
Yeah, thanks, Megan. So there's different provider types. So like if we have homemaker being provided and we have personal care being provided, those theoretically shouldn't be duplicative. Obviously, if there's AME involved, it'd be pretty difficult to do, you know, homemaker AME at the same time an individual is receiving personal care. So we definitely don't want to see those sorts of things happening. But there may be instances where a homemaker provider is providing homemaker services at the same time a member is receiving personal care services. And then I believe the second part of your question was regarding 24 hours a day and exceeding 24 hours a day. And I would say, I don't want to provide a hard stated response about the amount of care an individual can get in a given day, because it is going to be member specific. We wouldn't expect to see members needing more than 24 hours in a day consistently. It's going to be a very few and far between group of people that would receive more than 24 hours in a day. So I hope that answers your question.
It does. I think in general, it'd be helpful to have an FAQ that talks about what is considered duplicative, like what things could happen at the same time and what things couldn't. And it ties in this FAQ that says like the member doesn't have to be there. And so that idea that homemaker could happen at the same time something else is happening, that many agencies just say no to because it makes them scared and nervous, rather because there's no clear guidance on that.
Thanks. That's helpful feedback. I'll just clarify too, we are working on some additional documentation regarding, like, specifically, we're working on age appropriate guidelines just to help with that service planning. And then as far as like what's duplicative and not duplicative, I think we can explore if there's additional guidance that we can provide. But I also want to state too that these areas are really difficult to make a hard stated policy for, because each individual is going to be completely different. And so in some circumstances, it would be duplicative to have 2 providers there. In other circumstances, it may not be. And so I think we can look for ways to incorporate that direction into some of our existing guidance. But it is really individualized too.
Thanks, Danny. I see Laura, you brought your hand up.
Yeah, I just wanted to make sure that we're being very clear when we're saying stuff on these meetings that say we're allowed to do services at the same time. I want to make sure that the billing rules line up with that. I know that it has been a huge stigma in Medicaid for very long that 2 services cannot be happening in the home at the same time. The reason for care coordination with skilled agencies when we're a non-medical agency going in the home has always been you have to align, like you can't be there doing homemaking if the CNA's in the home, or like just please make sure that we're very clear and we're not misadvising people, because I think a lot of people are going to be like, oh, I can send my homemaker in the same time that personal care is happening. And if it causes issues with billing, and we're getting kickbacks all the time because our clients are in the hospital the same day that we're getting in there doing care, and we're not getting paid for those days because the hospital got paid. And so I just want to make sure that we're very clear when we're saying that services, I know we bill them separately, but that just gets really sticky with some people. And it may not be you guys, it might be licensure people, it might be the surveyors, and it might be the billing side of things. So I just want to make sure before we do clarify that all of those areas are looked at, and even CDPHE is kind of given the, oh, we agree with that, because I do know that that's something they look at when they're surveying.
Thank you, Laura, for that feedback. Okay, because we only have 5 minutes left, I want to make sure we get to the last few things of our presentation today, and then save time for any other open forum questions. So if you have any other thoughts or feedback on that FAQ, please, put it in the chat or email us, and we'll take that into consideration. Okay, so I'm gonna kind of skip through this section because this is kind of open forum-y, in terms of just hearing from you about how things are going with CFC enrollment. And I want to make sure to just briefly touch on these council meetings. So because CFC has officially launched in July, we are kind of taking a look at the frequency of these meetings and potentially reducing the frequency. So, for example, we might move to every other month or quarterly, and then adding ad hoc meetings if needed. We would love your feedback on this plan, and just to know, what are other things you'd like us to cover in this meeting. If you have ideas, what's been working, what hasn't been working. We created a survey for you to provide that feedback to us. So, anytime this month, if you want to take that survey, we would love to hear your feedback. We'll collect it and, kind of talk about our ongoing plan with your feedback incorporated next month. So, just want to make sure to plug that. And if we can are we able to put that survey link in the chat? We may not be able to, since it's a Google form, but if we can, let's put it in the chat. If not, you can access that link on our slides once we get these posted.
And yes, the link is in the chat, so everyone knows to grab that.
Okay, great. Thanks, Rachel. Okay, and then office hours. We have case management office hours upcoming on October 7th and October 21st. As always, more dates can be added if needed, so keep an eye out for more case management office hours dates. They become available. And then nurse assessor office hours, I believe we have one tomorrow on the 2nd at 10 a.m. and then again toward the end of October, beginning of November, and mid-November. All of these can be accessed via the stakeholder calendar, the OCL stakeholder calendar. Alrighty, and with that, I'll leave the last couple minutes for open forum. I apologize, I know we usually try to leave more time for this. So yeah, Daniel, go ahead.
All right, can you hear me okay?
Yes.
Wonderful. So hopefully this is the right place to ask this question, but we've been kind of having confusion or maybe some different perspectives on how all this works. So let me just ask the question. Under CFC, what is the role of the home care agency in contributing to the care plan development with or without the RN assessor?
Thanks, Daniel. So you're asking, just to make sure I have it correct, you're asking what is the agency, the provider's responsibility in contributing to the member's service plan after the nurse assessor has made their recommendation?
Yes, but I guess also adding in, so that would be in the case that we have the health maintenance activities. Also, if we just have the homemaker and personal care worker, what would be the process there? Is it different between the two? And then I think kind of just speaking a little bit more towards the confusion is we've got some of our case managers that are very much taking the stance of the agency, the home care agency, does not have any part in developing the care plan. And essentially we get the PAR before we've even given any kind of feedback on the care that we've been providing and our care plan, I guess, that we would, or the edits that we would recommend. So in some cases, we're getting absolutely no part in that at all. And then in others, we are able to work with a case manager to kind of give a little bit of feedback on what we're seeing in the home. And so really just trying to find kind of a standard expectation, if there is one, as to what that process looks like.
Absolutely. Thanks for your question, Daniel. And I see Amanda Smith from our PDP team. You have your hand up. Go ahead, Amanda.
Yeah, thanks, Eileen. Hi, everyone. My name's Amanda Smith. Daniel, thank you so much for those questions. I think from what I heard, it sounds like a couple different scenarios, whether it's service delivery of IHSS, maybe agency-based. So I would really love to connect with you offline so we could get that clarification, or we could discuss it at the next meeting, because I would presume that there's other agencies on the call right now with similar questions. But overall, I would say that kind of depends on our IHSS care plan versus agency-based, but happy to talk through that more or give some more guidance in our FAQs.
Okay.
Okay, thanks, Amanda. Phil, I see you're up next.
Hello, can you hear me?
Yes.
Hi, perfect. Hi, my name is Phil. I'm just someone basically observing your guys' as in Colorado's community first choice program. And as someone that has expertise as well as experience in other person-centered based programs like Community First Choice, in different states, it's called Community First Services and Supports. I feel like then this is kind of like a feedback and as well as a question into one, so I apologize in advance. But it seems like there's kind of like a gap between the case management and the service providers in itself. And one thing that I've noticed that other states and programs have done is they've instituted a consultation service provider to kind of close that gap, right? That way people who are receiving services can make sure that the services they receive are indeed person-centered based and the case managers don't have too much on their load. So what I've seen from other states would be the people like us, consultation service providers, would be the ones to write the care plans. Case managers would be the ones to approve it in a way. And the HCPF and whoever is kind of overseeing everything would be the ones to mediate and kind of have the guidelines for the program, as you guys do yourselves are already doing. So that being said, I was wondering, if has anybody introduced the idea of involving a consultation provider to kind of mediate and be the middleman between things? And if not, is there any way we can kind of implement this into this program so that people alike can all receive the services they need, as well as kind of taking pressure off the shoulders of everyone? Has that been something that has been discussed?
Thanks, Bill, for that feedback and those ideas. As far as consultation services go, we haven't really, delved into that as far as incorporating it into the structure of CFC. But happy to connect with you outside of this meeting if you want to email us with some of your thoughts. And we're always looking for feedback on program and Medicaid structure at large. So happy to hear your thoughts and kind of connect with you offline if that works.
For sure. Thank you.
Yeah. Okay, Irina, go ahead.
Yes, I wanted to add to what Daniel said. Since implementing CFC since July, we as providers, well, I particularly have noticed that the case managers are no longer asking for matching care plans to the calculators that establish whether it's IHSS or agency direct service. They just send you the calculator and the PAR. Can you put it maybe in the FAQ somewhere for case management that is still a requirement to have a kind of a dialogue, as Phil said, between the case manager and the provider as well as the clients, because sometimes they don't know what they were approved for, and we don't know if it still matches to a previous year calculator. So whatever we had before worked fine. We kind of were on the same page, and if that can be put back, if it's not, I think it's part of it, but case managers in its massive majority is not requesting those care plans. Thank you.
Yep. Thanks, Serena. Amanda, so you got your hand up.
Yep, I do. Thank you. And thank you for that feedback, Irina. Yeah, we do have quite a bit of guidance in our training around that, but happy to take that back and see what we can do to relay that to case managers, because there should be a discussion, particularly, especially for IHSS. We do have the IHSS agency care plan that's required, and that is prior to the start of services. It does not have to match exactly the direct care services calculator provided by the case manager, but overall the hours should align. But yes, if you're seeing that that discussion is not happening, happy to take that back and see what we can do to provide some more guidance.
And I might make a plug too that we did issue a memo about kind of roles and responsibilities for case managers and providers around the direct care services calculator. I think maybe a month ago. So we, encourage you to take a look at that and, let us know if you have any additional questions or if anything in there is not clear. Alrighty. Well, I know we are 6 minutes over time, so, I want to just make sure to wrap a few things up. Here in our slides is a link to all of our most recent resources. If you need any of these, most of these are available on our CFC stakeholder web page, so you can always go there for these resources as well. And then again, any other questions that you have that we did not get to today, either in chat or verbally, because I know we may not have gotten to all the questions in the chat, please feel free to email us. Our email is hcpf_cfc@state.co.us. So, we're always happy to connect with you offline, or if there's anything that didn't get answered today, please reach out. Alrighty, with that, I think I'll go ahead and close us out. We really appreciate your dialogue today and your feedback and your questions. And we look forward to hearing from you about our CFC Council meeting frequently. So please take that survey if you can in the next month. And we'll talk to you all in a month. Thank you so much.